you mentioned trending the proteinuria, albuminuria. I hadn't really associated, I usually think of doing that for people with diabetic kidney disease. But what about with primary aldosteronism? Are patients more likely to have hypertension that also has proteinuria? And with the CKD, is that part of the progression, like say it goes untreated?
If I see a lot of people with severe hypertension that's just been going on for years, and even though hypertension shouldn't have massive proteinuria, you can have quite a bit of proteinuria even with severe hypertensive disease that's just gone on for a long time. And
Mm.
if I want to see what direction they're headed, if they're treated aggressively, their blood pressure's recently been improving, and then I also see that their proteinuria is improving, that's reassuring to me. The real thing I want to make sure is that I'm not missing another kidney disease. So I'm not missing a glomerulonephritis. Occasionally somebody comes to my clinic that has a glomerulonephritis. Um, if they've got a lot of blood in their urine, I'll make sure that I'm paying attention to that and there's not some other urologic explanation for it. But if they have, glomerulonephritis, though, they may need a kidney biopsy, especially if it's brand new AKI, a brand new kidney disease, proteinuria, hematuria. You
Mhm.
obviously take that much more seriously and don't just blame that. Primary aldo does not cause hematuria and proteinuria. It doesn't cause like a full-blown glomerulonephritis. So that would be something
Mhm.
totally different.
Paul's initial question, so what else would we do? It sounds like you're looking for end organ damage. So the EKG, is there LVH, early repolarization that might lead to an echo? As we just talked about, sort of looking how bad's their kidney disease? How much proteinuria do they have, if any? What's the trend of the creatinine? And then you said also just looking at the scans yourself, kind of the Hounsfield units, are there any nodules there that weren't commented on? And then you said also maybe looking for cortisol, excess cortisol secretion. So thinking about that work up there with a dexamethasone suppression test. Um, and so now, let's say that stuff, they don't have this patient, CJ, our 55-year-old man, doesn't have uh, hypercortisol. The Let's just say the creatinine is has been stable, and let's say we see some LVH. Echo doesn't look too bad, like grade 1 diastolic dysfunction, which like
As go we all.
the old
Yeah.
joke that everyone has it. So what else would you do next to confirm PA in this person, primary aldosteronism?
So in this particular patient, I'm not sure that I would do a whole lot more testing. I would
Mhm.
probably opt to go straight to treatment for this person.
Mhm.
And I think they have a lot of things that kind of indicate that they're high risk. So they've got uncontrolled hypertension. Their diabetes is marginally controlled, not too uncontrolled. But they've got CKD. So those are pretty high cardiovascular risk factors right there, along with the LVH would add to it. So I would push pretty hard to reduce blood pressure. Maybe not necessarily to 120 or below, but as close as I can. My approach to that is I try to get everybody to less than 120, but you do run into problems, and sometimes that makes you stop or pull back just a little bit.
So to remind the audience, this person's on hydrochlorothiazide 25, telmisartan 80, amlodipine 10. How might you tweak this regimen off the bat, and what else might you add or change?
The first change I probably would make off the bat is switch to chlorthalidone 25 milligrams. It's milligram per milligram. It's more potent. I know the study recently showed no cardiovascular differences, but
Mhm.
25 milligrams of chlorthalidone is more potent than 25 of HCTZ. There's pretty good evidence now in CKD that chlorthalidone at that dose is going to be beneficial. So that also may make a difference. So I would do that. It would also lower potassium a little bit more than just HCTZ alone. So that may actually be a benefit and help us get this patient to tolerate an MR antagonist.
Mm.
And now I think an SGLT2 inhibitor is indicated for this patient too. They've got CKD proteinuria. So an SGLT2 inhibitor also would help lower potassium a little bit, or at least constrain it if you did add an MR antagonist. So I think all those things probably need to be done here, given that their blood pressure is pretty far away from being in the goal range.
I realize this is a case by case basis, but how I would think sort of once you know putatively what's causing the hypertension, I wonder why you wouldn't prioritize an MRA as opposed to sort of, I mean, obviously the SGLT2 makes sense, just sort of go the background diabetes and all the known protections with that. But I guess, let me ask the question a different way. How likely are we able to get this patient controlled without an MRA, sort of, tweaking the medications that we have in place already? Is that a realistic expectation?
Yeah, honestly, I would probably do that at the same time. I would probably, if potassium allows, add spironolactone as well as change to chlorothalidone.
Gotcha.
So it does depend on what the potassium is and whether they have hyponatremia, which is always a confounding factor, and also how stable their creatinine is. This patient's creatinine is pretty stable, so it's a little bit risky whenever their creatinine is, they've got CKD3. I do use quite a bit of spironolactone in these patients and watch really closely. And creatinine will go up when you initiate all these treatments and lower blood pressure as well. So we will have to counsel them and warn them. Creatinine is going to go up when we lower blood pressure, no matter what we use, but we know that it's going to go up when we start spironolactone, especially.
Yeah, you were mentioning this to me when we did sort of our pre-interview. You were saying that are these people, are they sort of hyperfiltrating because they have unopposed aldosterone kind
Yes.
of, and they're hyperfiltrating, and then once you relieve that, we expect the GFR. Is that because aldosterone's clamping the outflow from the glomerulus? So it's clamping that down, so they're hyperfiltrating, and then when you relieve that, all of a sudden there's less pressure, so their GFR goes down. We were
Well,
talking about simplistic explanations before, but
yeah,
how does that work?
simplistically, aldo excess causes glomerular hyperfiltration. So that is going to make their GFR look better than it truly is, so that there's probably some underlying kidney damage, even more pronounced than what we suspect based on the labs. So if you start them on an MRA, creatinine is going to go up because you're going to prevent that hyperfiltration. In the long run, it's a good thing, just like it is when we prevent that with an ACE inhibitor. Now also with an SGLT2 inhibitor, we think it does the same thing. We know that people with primary aldo have the same hyperfiltration. In fact, if you send patients to adrenalectomy and cure their primary aldosteronism, creatinine, it can go up significantly because a lot of those patients are completely inadequately treated until they get adrenalectomy. So creatinine can go up significantly after adrenalectomy. And I've seen that a few times and been surprised myself, even though I know it can happen.
Yeah, Paul, this seems like this would make me scared, right? Because you're like putting them on the right medication.
Mm-hmm.
Once you get the dose right, their creatinine's going to get worse.
Yep.
I'm not sure how I'm going to handle this practically.
It
a good
doesn't.
nephrologist by my side.
Yeah, I haven't done this. I haven't seen, a huge increase in creatinine, and I'm a nephrologist, and so I'm a little more comfortable with creatinine going, up to 3 from 1.5 to up to 3, and as long as it's stable, I've got patients that had severe hypertension. You get them on all these right medicines, you bring their blood pressure down. I've seen 2 people within the past week that I started treating 10 years ago. And when I brought their blood pressure down, put them on MR antagonist, creatinine did go up to about 3. And I've got quite a few patients whose creatinine went up to 3, and it's stayed there over 10 years. It hasn't gotten any worse. But you take the biggest hit when you first lower blood pressure, when you first put these people on the appropriate medicines. But long term, as we've always seen in the trials, it stays there and it has a slower decline. And I just anecdotally, I see that in these patients that I'm seeing that have stable CKD3, kind of people that I've been telling for 10 years, we're going to have to think about dialysis at some point. But it's stayed stable. Now, that's not everybody. There are people that progress to end-stage renal disease. And the biggest thing I worry about in these people, in these patients, is that their biggest risk is cardiovascular risk. So by far their biggest risk is not necessarily developing kidney failure and needing dialysis. Their biggest risk is developing a stroke, heart failure, and dying. That's much more likely than them going on to end-stage renal disease.